Good afternoon, everyone. My name is Vikas Gupta. I'm a hematologist at the Princess Margaret Cancer Center in Toronto, Canada. I'm moderator for this special session on stem cell transplantation and accelerated phase and blast phase of MPN. We have three talks in today's session, and I will be speaking on the topic of MPN and stem cell transplantation. The second topic for today's session will be risk factors for progression in myeloproliferative neoplasm by Dr. Andrew Kuykendall from Moffitt Cancer Center in Tampa, Florida. And finally, Dr. Verstovsek from MD Anderson Cancer Center, Houston, will be discussing therapeutic strategies for accelerated phase and blast phase of MPN. So thank you, Dr. Mesa, Verstovsek, Pemmaraju, and the organizing committee for the opportunity to share my thoughts on stem cell transplantation in myeloproliferative neoplasms. These are my disclosures. The objectives of this presentation are to understand the key issues in transplantation for myeloproliferative neoplasm, who are appropriate candidates for upfront transplantation for myelofibrosis, and what is the optimal timing of transplantation in myelofibrosis. These are some of the important issues one need to consider for transplantation for myelofibrosis. Transplantation is usually reserved for relatively younger patients with good performance status and free of comorbid condition. An important consideration for transplantation is disease severity or risk status of the patient. What is the optimal timing of the transplantation? Should you offer transplant as an upfront therapy or at the failure of non-transplant therapies such as JAK inhibitor therapy, or should you wait until disease transforms to blast phase or acute myeloid leukemia? Once you have decided to go for transplant, should you use full intensity or reduced intensity? What is the optimal graft versus host disease prophylaxis? Does donor type make a difference, or should a donor is a donor approach should be used? When should patient undergo splenectomy prior to transplant? And what role ruxolitinib may have in the context of transplantation in myelofibrosis? I will discuss some of these issues highlighted in red ink in more details. From disease risk point, ELN and NCCN guidelines or expert recommendations suggest offering transplant to myelofibrosis patient with intermediate to or high-risk disease. In addition, transplantation is recommended in patients with intermediate 1 risk disease who have additional high-risk features such as high-risk cytogenetics, high molecular risk mutations, presence of severe cytopenia such as transfusion dependency or severe thrombocytopenia or increasing blasts in the peripheral blood. These recommendations are based on the impression that survival is less than 5 years in these patients, justifying the risk associated with transplantation. So what data do we have to support these recommendations? It is important to note that high-quality evidence backing these recommendations is lacking, and there are no prospective comparison of transplantation versus non-transplant therapies in patients with myelofibrosis. Limited data from retrospective studies are available. However, patients treated with JAK inhibitor therapy are small in these studies, and the JAK inhibitor has become standard of care for symptomatic patients with myelofibrosis. There are two major retrospective studies which have addressed the question of transplantation versus non-transplant therapy. The first study was published in Blood by Dr. Kroger and colleague, and here the transplant patient received transplant in Germany and Seattle, and non-transplant cohort was provided by the Italian group. The second study has recently been published from the CIBMTR in collaboration with several North American centers who provided the data on non-transplant therapies in myelofibrosis patients. In Dr. Kroger's study, outcome of transplantation in low-risk disease was inferior in comparison to non-transplant therapies, whereas the outcomes in for intermediate 2 and high-risk disease was in favor of transplantation. Outcomes of in the intermediate 1 risk disease were similar, and the authors recommended case-by-case consideration of transplantation for intermediate 1 risk patient. However, applying these recommendations in the routine clinical care can be tricky sometimes. Let's try to apply these recommendations in a real-life scenario. This is a patient from my clinic who is a delightful 66-year-old lady who was diagnosed with CALR-mutated primary myelofibrosis in 2015. At presentation, patient had anemia, normal white blood cell count and platelet count, and had 1.2% blast cells in the peripheral blood. Patient had asymptomatic splenomegaly, which was palpable by 5 cm below the costal margin. There were no constitutional symptoms. Cytogenetic studies showed normal karyotype. Targeted sequencing using a broad myeloid panel did not show any high-risk mutation. If we look at the risk stratification, this patient falls into high-risk category using IPSS or intermediate 2 risk category using DIPSS. So according to the guidelines or expert recommendation, this patient could be a potential candidate for transplantation. However, we did not feel that transplant was required in this patient, and we carefully followed this patient, and this patient continues to remain asymptomatic, and only thing which has changed in the last 5 years is drop in her hemoglobin from 96 to 89 as observed few months back. Therefore, it is important that we make individualized decision for transplant in each patient after understanding the natural history of the disease, particularly what is expected survival and what is risk of transformation to blast phase or acute myeloid leukemia. Our ability to understand the natural history of the disease has significantly improved in the recent years. This cartoon represents major risk scores described in patients with myelofibrosis. In the last 20 years, we have gone from some very basic scores, such as Liller score, which relied on risk stratification using hemoglobin and white blood cell count, to more sophisticated scores, which take into account histopathology, cytogenetics, and molecular studies. These risk scores enhance our precision for the risk stratification. It is also important to understand the tempo of the disease, as highlighted in the case study I just presented. Some patients will have a very indolent disease course, whereas others may have very rapidly progressive disease course. Other factors to consider would be what are the potential alternatives to transplant the patient may have, and what are their preferences. Thoughtful consideration to all these factors help in discussing and formulate a strategy with the patient about the potential timing of the transplant. In a potential transplant candidate, consideration should be given whether patient may benefit from upfront transplant strategies, or delayed transplantation would be reasonable, or transplant at the time of clear progression to blast phase or acute myeloid leukemia. Here, the upfront strategy means transplant is required in the coming few months, where JAK inhibitor therapy may be used to reduce the symptom burden as a bridge to transplant. Delayed transplant strategy means patient can continue non-transplant therapy such as JAK inhibitor as long as patient is benefiting from the treatment, and consider transplant if patient start developing any cytopenias, toxicities, or having suboptimal or start losing the response which requires a change in therapy. We caution the patient against the third option, which is waiting for progression of disease to accelerated phase or blast phase. The outcome of patient who progress to MPN blast phase is extremely poor. Very few patients are able to reach the transplant in this setting, and even those who are able to reach the transplant stage, the outcomes are suboptimal. These are the recent data reported from CIBMTR, where comparison of MPN blast phase patient in remission is done with de novo AML patients in remission. So the main decisions come between whether patient should receive upfront transplant versus delayed transplant strategy. Do we have any data to support whether one strategy is better than the other? So this is a recent study our group has completed. My colleague, Dr. Mays from Princess Margaret, has led this study involving 8 centers in United States and Canada. We collected data on approximately 500 patients under the age 70 years and treated between 2012 to 2017. The reason for selection of this time period was ruxolitinib was widely available in United States and Canada for symptomatic patients with myelofibrosis. Of these 500 patients, 311 patients were treated with either JAK inhibitor therapy or transplant as upfront therapy. There were 222 patients in the JAK inhibitor who received JAK inhibitor therapy as upfront therapy, and 86 patients who received transplant as an upfront therapy. If a patient received JAK inhibitor therapy as a bridge to transplant, they were counted in the transplant arm. If a patient received transplant after failure of the JAK inhibitor therapy, they were counted in the JAK inhibitor therapy arm. And 20% of patients who received upfront JAK inhibitor therapy later on received transplant as a salvage treatment. The survival in this study was in favor of transplant arm. However, the improvement in survival only becomes apparent around 5-year mark. There is a higher early mortality in the transplant arm if you focus in the first 3 to 4 years on these curves. These data suggest that potentially we can avoid some early mortality related to the transplant in some patients by offering upfront transplant only to the patients who are unlikely to do well on JAK inhibitor therapy. So the next question is, can we identify patients who are unlikely to do well on JAK inhibitor therapy? This is a study from Princess Margaret where we showed that patients who have high-risk DIP score, patients who are transfusion dependent, and patients who have mutations such as ASXL1 or EZH2 have a shorter duration of response to JAK inhibitor therapy and have a high risk of JAK inhibitor therapy failure. So potentially these patients could be considered for an upfront transplantation, whereas the patients who do not have these risk factors could be treated with JAK inhibitor therapy and considered for transplantation at the failure of JAK inhibitor therapy. So this is our approach for upfront transplantation in myelofibrosis patient at Princess Margaret. We offer transplant to any patient who has TP53 mutated myelofibrosis, given the poor survival, median survival is 2.4 years in this group. If cytogenetics and mutation data is available, we risk stratify the patient using MIP70 plus risk stratification, and in patients who fall into high risk or very high risk category, we offer upfront transplantation to those patients. If cytogenetic results are not available, then we risk stratify patient using MIP70 score and offer transplantation to patients who fall into high risk category. Other patients are treated with JAK inhibitor therapy as appropriate and considered for transplantation if they start showing any signs of JAK inhibitor therapy failure. Now, we know that these are some of the patients who are not likely to do well on JAK inhibitor therapy. However, what we don't know is whether transplant will help these patients or not. Therefore, we have designed a prospective study, which is AlloBat study, and this is a pan-Canadian study, which will compare the outcome of patients treated with transplantation versus best available non-transplant therapies in patients with high-risk myelofibrosis. And high-risk myelofibrosis will be defined, as I highlighted, using MIP70 or MIP70 plus score, or patients who have TP53 mutated myelofibrosis. So what role ruxolitinib may have in patients with myelofibrosis as a pre-transplant therapy? When ruxolitinib was approved, a lot of us had hoped that ruxolitinib will help us in overcoming some of the issues associated with transplantation in patients with myelofibrosis, particularly high risk of graft failure and high risk of graft versus host disease. Ruxolitinib does help in reducing the symptom burden in patients with myelofibrosis by reducing the spleen size and reducing the burden of constitutional symptoms. Several groups have investigated ruxolitinib prior to transplant in patients with myelofibrosis. This is a study schema of a study which was conducted through MPN RC consortium, where ruxolitinib therapy was given for 60 days prior to the transplant. Patients were given 56 days of full dose ruxolitinib therapy, and ruxolitinib therapy was tapered over 4 days, and patient was started on reduced intensity conditioning consisting of fludarabine and busulfan. While the study established that this approach was safe in patients with myelofibrosis, we did not observe any significant improvement in graft failure in this study. A lot of patients coming to transplant are now being treated with ruxolitinib therapy. It is important that we gradually taper ruxolitinib in these patients prior to the transplant. And our approach is to continue ruxolitinib therapy and start tapering around 4 to 5 days prior to the planned date of conditioning therapy. There have been some reports where ruxolitinib has been stopped prematurely prior to the start of conditioning therapy, and certain side effects such as ruxolitinib withdrawal symptom resulting in pulmonary infiltrate, ICU admission have been reported in some of these patients. So a few take-home messages. Individualized decision making is required at all stages. Transplant age appropriate patient should be seen at a specialist center for assessment for a transplantation. Upfront transplant decision in myelofibrosis can be complex and be carefully considered in selected patient. If transplant is not considered as upfront therapy, we should revisit suitability for transplantation regularly during the disease course and offer patient transplant at the early signs of JAK inhibitor therapy failure. Thank you. The next topic for today's session is risk factors for progression in myeloproliferative neoplasm by Dr. Andrew Kuykendall from Moffitt Cancer Center in Tampa, Florida.
My name is Andrew Kuykendall from Moffitt Cancer Center, and today we'll be discussing risk factors for progression with myeloproliferative neoplasms. And first off, I just wanted to thank the organizers of this conference, Drs. Mesa, Verstovsek, and Pemmaraju, for allowing me to speak on this topic. I think it's certainly an exciting topic and one that we can kind of look at from many different perspectives. But In an attempt to stay organized, I will start with kind of going over our classic definitions of progression for the various myeloproliferative neoplasms. Then we'll address some clinical and genetic risk factors. I'll introduce some risk models for progression. And then we'll kind of take a detour into discussing some of the biologic bases for progression in myeloproliferative neoplasms. And within that, we'll touch a little bit on inflammation, this concept of it being a risk factor for progression. And hopefully in that kind of detour, we'll identify some potential targets for progression. So here are our consensus definitions for progression for the various MPNs. And these really focus on kind of transformation from one disease entity to another. And so for ET, you can see that transformation is defined as progression into either polycythemia vera, myelofibrosis, myelodysplastic syndrome, or acute leukemia. Similarly, for polycythemia vera, progression is defined as transformation to myelofibrosis, myelodysplastic syndrome, or acute leukemia. For myelofibrosis, it's a little bit more nuanced, whereby you can have progression to acute leukemia with 20% blasts seen in the peripheral blood or in the bone marrow. But you can also have progression of splenomegaly as defined based on what the starting spleen size is. And these are helpful for clinical trials to get a uniform definition that can be used. However, they're limited a bit in their scope since they fail to kind of address progression of cytopenias like anemia and thrombocytopenia. And they don't really address cytogenetic or molecular evolution or progression of symptoms. So there's just a few different lenses that I think through which I think we can view progression. So we can think about progression genetically, whereby patients start with a mutation, a low-level mutation like clonal hematopoiesis, and ultimately this progresses to a relevant driver mutation, and then increases the burden of mutation to make it more of a homozygous driver mutation, and increasingly develops molecular complexity and high-risk genetic abnormalities. Clinically, this may kind of start with just proliferation of disease and progress to develop more symptomatology, extramedullary hematopoiesis, progressive cytopenias, and then cellular immaturity that can be seen with acute leukemia. Morphologically, the pathology may show kind of just hyperplasia of the megakaryocytes, which then may evolve into more hypercellularity, panmyelosis, and then this can further progress to seeing atypia, fibrosis, dysplasia, and increasing cellular immaturity. And this all kind of correlates with the disease progression from ET as potential starting point through polycythemia vera, myelofibrosis, with an increasing MDS-MPN phenotype, and then maybe secondary acute myeloid leukemia. So here's some various terminology that can be used to kind of say the same thing and kind of define a disease that's turning into a worse form of itself. So we can say evolution, transformation, progression, certainly relapse. So this is a summary slide, kind of going over the clinical risk factors that have been described within the setting of, within context of myeloproliferative neoplasms. And certainly, as you can see from the reference list here, the bulk of literature kind of has been in looking at what clinical factors can identify patients at risk for transformation. But the problem or the issue with clinical risk factors is a bit of a chicken or an egg problem. And so if you look specifically, let's say from a progression of ET to myelofibrosis, two of the risk factors that are listed here are anemia and an increased LDH. And within ET, anemia is relatively rare, as is an increased LDH, but these two factors are actually part of the diagnostic criteria for post-ET myelofibrosis. So it's a bit of a self-fulfilling prophecy to say that these factors are there in risk factors for developing MF if they're part of the diagnostic criteria. It's kind of similar to saying that someone who has lottery numbers that match the winning lottery numbers is more likely to win the lottery. So I don't know how helpful it is in that sitting, but it does emphasize the fact that you can kind of witness progression or get a feel for a patient that's progressing by looking at their clinical factors. More to the root of the problem is looking at the genetic risk factors. And when we talk about progression to myelofibrosis, we've identified, potentially in an ET patient, a non-JAK2 A driver mutation may hold an increased risk of progression. In the setting of polycythemia vera, an increased JAK2 allele burden can be a risk factor for progression. And interestingly, again, within ET, this translocation 19 may be a cytogenetic finding that may spur an increased risk of progression. But ultimately, we understand that progression is linked to these driver mutations, as myelofibrosis seems to be the natural end result of a long-standing MPN. Kind of in contrast, when we look at a progression to AML, this isn't necessarily a natural progression, and it takes additional mutations within the p53 axis, including a deregulation of p53 with MDM2 and MDM4 overexpression, increasing molecular complexity with other high-risk mutations, genomic instability with unfavorable and monosomal and complex karyotypes. But clearly, this is a disease that becomes more unstable, and some mutations drive that process. The Mayo Clinic's attempted to develop multiple risk models to predict progression to acute leukemia, and some of the early ones incorporated factors such as thrombocytopenia, which we mentioned as a clinical risk factor, as well as unfavorable or high-risk karyotypes and an increased amount of peripheral circulating blood blasts. More recently, they've proposed a leukemic a transformation model that incorporates IDH1, SRSF2 mutations, ASXL1 mutations, in addition to age, circulating blasts, and anemia. Peter Campbell's group has recently published this personalized prognostic model for myeloproliferative neoplasms, which I think is certainly an intriguing model to use. And overall, this study kind of incorporated data from 2,000 patients, most of them being ET patients, and it assessed 63 different clinical or genomic factors to assess their influence on progression to myelofibrosis or acute leukemia. At the top, you can see the relative influence of various factors on myelofibrosis transformation. And you can see that the genetics of the disease account for about half of the risk in developing myelofibrosis. And this is similar to what we see with the risk factors for developing acute leukemia. Clinical factors seem to make up the rest of the risk, with some cohort-specific factors being present in the risk of transforming to acute leukemia. And while the genetic influence is pretty similar as far as the progression to MF or AML, you can see that the specific genes are a bit different, whereby in the genes associated with progression to acute leukemia, you can see RAS pathway mutations, RUNX1, P53, in addition to SRSF2 mutations, which are seen as a risk factor for both MF and AML transformation. This model also comes with an online tool that certainly can try to provide an individual prediction for patients as far as their risk for progression to MF or AML. And certainly this doesn't reach, quote unquote, crystal ball status, and take all the thinking out of prognosticating for these patients. But it is intriguing to kind of place in some of the clinical and genetic variables associated with an individual patient and gain a sense for what the probable outcomes may be. And I know that was a quick kind of review of the clinical and genetic risk factors. But while these are helpful to identify patients who are or have a high likelihood of progression, they're largely unsatisfying because most of these are non-modifiable. Obviously, we do have some emerging therapies that can target certain mutations, but these are certainly rare cases. So then the question arises: what risk factors or drivers of progression can we potentially alter? And herein I'll kind of address the concept of inflammation as this driver, this key driver of MPN progression. And the term inflammation certainly oversimplifies the concept, but increasingly we're understanding that extrinsic, intrinsic, and disease-driven inflammatory pressures drive this progression of MPNs, and potentially these can be modified. But ultimately we're asking, what allows for the progression from clonal hematopoiesis to a clinically relevant driver mutation, and so on down this route. So this is a study from the Danish group that addresses 20,000 people that were screened for JAK2 and CALR mutations, and ultimately it shows that there's the presence of a driver mutation, largely JAK2, in about 3.2% of this population. And you can see here that the incidence of these driver mutations increases with age, as does the burden of disease, suggesting that first off, these mutations aren't necessarily rare, and they seem to be selected for over time. And looking at this kind of relationship between inflammation and MPN progression, these figures help to kind of illustrate that. And on the left here, you can see this vicious cycle of MPN progression, whereby an MPN driver mutation produces inflammation and is selected for by an inflammatory environment. So this is kind of like a bureaucrat that creates out of legislation some sort of high-paying job that's ultimately filled by himself. Similar to that, the MPNs seem to set themselves up for success. And on the right, you can see that as this inflammatory environment grows, so does the potential for genomic instability, and this fosters progression and transformation. Interestingly, given the seemingly kind of predictable nature of MPNs as a whole, there have been mathematical models that have been created that do a remarkable job of replicating that natural history of the disease based on really the starting condition of one single mutant MPN stem cell, and then this underlying knowledge of cell dynamics and the understanding that ultimately inflammatory pressure will select for an MPN stem cell. And then, within these parameters, there's the expectation that if you develop a single mutation in MPN stem cell, there will be this kind of significant latency period, whereby the normal blood cells will dominate and no MPN will be evident. But then after a certain amount of time, there'll be this kind of period of exponential growth, whereby the MPN cell population will outcompete the population of normal blood cells, and an MPN will develop. And this will evolve through kind of various phenotypes that we would classically associate with ET, PV, and myelofibrosis. And interestingly, the time frame in which this is predicted from these mathematical models seemingly lines up with what we see clinically. But interestingly, when you look closer at these mathematical models, one way to kind of adjust the trajectory would be to modulate the level of inflammation and that inflammatory pressure. And herein is some different ways in which you could kind of adjust the inflammation and see how the actual progression of the disease would be impacted. And so I think that serves as proof of concept for the idea that potentially if we target these inflammatory pathways, we could somehow modify the underlying disease. So how do we go about doing that, and what evidence do we have that says that inflammation is really related to this disease clinically? And so, first we know that inflammation broadly is associated with progressive disease and worse outcomes. Here's a study of looking at C-reactive protein, which is an acute phase reactant and a very general marker of inflammation, especially acute inflammation. And it's associated with an aggressive disease phenotype with anemia, splenomegaly, leukocytosis, and worse disease-specific outcomes here with a worsened leukemia-free survival. In addition to that, we know that there's this extrinsic inflammatory pressures also play a role, because this was a large meta-analysis of 2.3 million people looking at the impact of smoking, which leads to an inflammatory state, and showing that this is also linked to the development of an MPN, and that risk is correlated with smoking intensity, which kind of strengthens that causative relationship. Additionally, there's evidence that inherent inflammatory states are linked with MPN progression. And so this is a relatively provocative study that looks at microRNA 146A, and this is miR-146A is an important break in the NF-kappa B inflammatory pathway. And single nucleotide polymorphisms within miR-146A actually result in differential activity and different inflammatory states. Specifically here, it's the T allele that results in lower levels of miR-146A and overall an increased level of inflammation with increased cytokine production. And when you look at this, these SNPs within the context of patients that have polycythemia vera and essential thrombocythemia, you can see that homozygosity for the T allele actually correlates with an increased risk of fibrotic progression, suggesting this kind of innate inflammatory state actually fosters progression of MPNs. Similarly, folks have also looked at the IL-6 receptor and polymorphisms within the IL-6 receptor that lead to impaired IL-6 receptor signaling and dampened inflammation. Once again, here it's the T allele but this time this results in actually decreased IL-6 receptor function. So in this study, this actually was a study using that previously mentioned Danish registry, and they looked at patients with MPNs who had various, who had the presence of this T allele that correlates with a decreased level of inflammation. And what they saw is that carriers that had the T allele carriers that had the T allele actually had a decreased risk of developing either a JAK2 mutation or a full-fledged myeloproliferative neoplasm. And this seems as this correlation was strongest with folks that were homozygous for the T allele as opposed to those heterozygous, once again strengthening this support for a causative relationship. So we know that cytokines are actually the mediators that ultimately exert this inflammatory pressure. And many of these have been assessed before in various different studies. And here's kind of a summary slide, a Venn diagram that talks about the different cytokines that seem to have relevance in the various MPNs. And we know the Mayo Group has looked at this specifically nearly a decade ago, and specifically linked IL-8, IL-2 receptor, IL-12, and IL-15 as independently prognostic within myeloproliferative neoplasms. Angela Fleischman's group has focused on the role of TNF-alpha, which appears to be critically linked to MPN development and progression. And here you can see that this pre-existing TNF hypersensitivity then fosters the development of a randomly occurring MPN mutation and allows it to develop into a full-fledged myeloproliferative neoplasm. More recently, her group has added to that story, suggesting that actually it's blunted signaling through the IL-10 receptor, which kind of regulates TNF-alpha, that may be responsible for this tilted TNF-alpha IL-10 axis and ultimately produces this kind of chronic inflammatory state that allows for MPN progression and development. Interestingly, this IL-10 receptor signaling and this tilted axis, this actually could possibly explain the familial susceptibility to myeloproliferative neoplasms as altered signaling was noted not only in a polycythemia or an affected polycythemia vera patient, but also their unaffected twin. So this could explain why we do occasionally see these MPNs that run in families. It could be an inherited susceptibility based on this kind of altered inflammatory state. IL-1 beta has also been implicated in myeloproliferative neoplasms. It seems to be secreted by mutant hematopoietic stem cells and plays a role in fostering the development of myeloproliferative stem cells by inducing this neuropathy that suppresses these regulatory mesenchymal stem cells. Additional studies have also looked at kind of TNF-alpha and IL-1 beta and show that they preferentially support myelofibrosis-derived CD34 positive cells compared to cord blood-derived CD34 cells. You know, together, this TNF-alpha and IL-1 beta not only seem to enhance the migratory behavior of MF-derived CD34 cells, but also the clonogenic output, suggesting, you know, that these cytokines are critically linked to not only development of MPNs, but also potentially progression and some of the genomic instability that comes along with that. This IL-1 pathway is additionally intriguing because it links up with some other interesting cytokines and pathways that are linked to MPN. So it signals through the IL-1 receptor, which associates with IRAK, with IRAKs. And IRAKs are interesting since they may be IRAK inhibitory features that play a role in pacritinib's therapeutic profile. Is also linked to other inflammatory pathways that like MAP kinase and NF-kappa B, which we know play a critical role in MPNs, and seems to interact or induce or associate with other critical cytokines like TGF-beta, IL-8, and IL-6, which we've mentioned before. Even more recently, Rebecca Schneider's group has implicated platelet factor 4, or CXCL4, as being critical in the pathogenesis and progression of myeloproliferative neoplasms. And intriguingly, this has been proposed as potentially not just a marker or a a risk factor for progression, but also a marker of disease progression. And in her study, CXCL4 knockout mice resulted in an ameliorated MPN phenotype, reduced inflammation, and actually morphologic improvements. So that certainly didn't cover all of the work that's being done into the role of various inflammatory mediators and their role in progression, but hopefully it kind of gave a brief little overview of some of the potential exciting pathways that could be targeted if we want to hope to kind of impair and impact progression of these diseases. So as a quick summary slide, we initially went over some of the consensus criteria that define progression in terms of disease transformation or spleen volume progression. We also addressed some of the limitations of those current definitions. We also talked about various clinical and genetic risk factors that have been linked to disease progression, and specifically mentioned that when we talk about AML progression, we're specifically looking at P53 pathway, genomic instability, cytogenetic abnormalities, in those conversion events. Also, from Peter Campbell's work, it seems that the relative contribution of genetic and clinical factors appears to be relatively even. However, it's these inflammatory mediators that lie at the core of MPN progression and hold some potential for potential targeting in the future. However, there are some questions that arise with how do we target these inflammatory pathways? Which pathways? How do we target them safely? And interestingly, when is the best way to target these? Because it seems that potentially these cytokines may have relevance at different stages of the disease. So at this point, I'll conclude my talk, and I'll be happy to take any questions you guys have. Thank you very much.
The last talk for today's session is by Dr. Srdan Verstovsek from MD Anderson Cancer Center, Houston, who will be discussing therapeutic strategies in patients with myeloproliferative neoplasm in accelerated and blast phase.
Hello, my name is Srdan Verstovsek. I'm professor of medicine in the leukemia department at MD Anderson Cancer Center in Houston, Texas. Today I'm going to talk about therapy strategies for accelerated and blastic phase myeloproliferative neoplasms, or MPNs. As we know, there are three phases of MPNs based on a percent blasts. And if you go from the left to the right in this table, we see a chronic phase, accelerated phase, and a blastic phase, also known as a post-MPN acute myeloid leukemia. This applies to any type of classic MPNs, ET, PV, or myelofibrosis. And the blasts simply are the one that determine the phase. Less than 10% blast is a chronic phase, 10 to 19% is accelerated, and 20 and more is the post-MPN acute myeloid leukemia. This is judged based on a peripheral blood or a bone marrow blast. Now, if we talk specifically on post-MPN acute myeloid leukemia, there is some significant information about it in public domain. This is one of the slides that I utilize quite often to compare different types of the acute myeloid leukemia outcomes. What you see in a blue line, the top line, is the outcome of patients with the de novo acute myeloid leukemia. The worst one at the bottom in a gray color is actually what we are talking about today. This is the outcome of patients with the post-MPN AML, and has not changed, unfortunately, much over many years. And here is therefore a paper from 2005 that, as I said, it didn't change much. We have a lot to do. If you look at the left side, here is the comparison of the survival of the patients that are given supportive care, you see about 2 months, or patients that were treated about 3 months. So unfortunately, not much of a difference. And then on the right side, a comparison of the survival of the patients that were given chemotherapy, intensive chemotherapy. So median survival with no induction chemotherapy is 2 months. With induction therapy is about 4 months. Again, unfortunately, not much of a difference. But you can see on each of these slides or the graphs that there is a little tail of some patients really surviving very long. So let's focus on that. And this is highlighted here much better. This is a very small number of patients, about 50 plus patients from our own center some years ago, 2008, looking at the outcome of different approaches in therapy including the transplant, which is very important. And here what we see is on the left side that everybody basically dies very quickly unless there is a transplant. So there is no much difference, like it was published in 2005, in the survival of the patients that are given AML type induction chemotherapy, low intensity chemotherapy, or supportive care, unless they go to the transplant. This is on the left side. On the right side, again, comparison of the patients that are given induction chemotherapy and achieving complete response or not, and going to the transplant. And only patients that achieve complete response and go to the transplant do well. So you need to really achieve with intensive chemotherapy, if you use it, the response, a CR or CRI, to go to the transplant to be successful. People usually ask, why do we bother treating patients? Why not go directly to a transplant once you are transformed? Like with any de novo acute myeloid leukemia, you are not going to do that successfully. Here we have an outcome of patients that were transplanted in a blastic phase, whether they are in the CR or not. And you can see that patients that are not in CR after induction chemotherapy going to the transplant do not do well. So you really need to achieve CR and have a response to be successful or have a chance with the transplant. So overall, what is the chance of having a response to induction chemotherapy? Here is a nice summary from one of the review papers. You can see in the red boxes that induction chemotherapy has a chance between about 13 to about 60% chance of response. So I would usually say on average about 35 to 40% chance to have a CR. There is alternative to use of induction chemotherapy for post-MPN AML. And the first information about the utility of azacitidine came about 10 years ago from France. This is a summary of the very large study with azacitidine in patients with AML and MDS, and intent here was to analyze the utility of this drug in subgroups of a post-MPN AML from the large study and post-MPN MDS. That actually is not very common, to transform to myelodysplastic syndrome. So it's a combination of the two different groups here, and I don't have a clear answer what is the exact activity in post-MPN AML, but that was a very good signal for everybody else to try to utilize and see what the activity of hypomethylation agent is in post-MPN AML. Here you can see the overall response rate was about 50%, and about a quarter of the patients had a CR, and 11 patients had a PR. And since then, there are many publications on use of hypomethylation agents in post-MPN acute myeloid leukemia or blastic phase MPN. Here are examples of a couple that actually try, from a retrospective chart review, to compare the outcome of the patients that were treated either with intensive chemotherapy, or IC on these slides, or azacitidine or AZA. And you can see on the left side, there is no real difference. That is about survival, and it's about 8 months either way. And on the right side is about 9 to 10 months either way, and it has other subgroups, so perhaps it's not clear to see, but I summarize it at the bottom of the right graph, about 9 to 10 months overall survival. So outcome appears to be the same. Now, what we also learn along the way is that the patients that transform from chronic phase MPN to blastic phase MPN actually transform through accelerated phase. That is rather a rule. It's extraordinarily rare that overnight patient comes from chronic phase to blastic phase. Usually you see blast coming up. So this is highlighted in this paper from 2008, where you see in yellow color the time period as the patients move from chronic to accelerated and then on to the blastic phase. Now that is then useful because we want to intervene sooner. We don't want to wait for patients to really transform. If we can follow patients closely, we would be intervening with hypomethylation agents in accelerated phase. So here is an analysis of utility of decitabine, alternative hypomethylation agents, in AP and BP. AP is accelerated phase, BP is blastic phase. You can see on the left side is the overall survival of patients in accelerated phase, about 10 months. But what is on the left side in the lower part is the difference between the responders and non-responders. There appears, this is retrospective chart review, some benefit of decitabine on the overall survival of the patients if they do respond to decitabine when they are in accelerated phase. The same applies to the blastic phase. Look at the right side, median survival 7 months in the top part of the right side, and in the lower part 10 versus 4 months for the responders versus non-responders to decitabine. So some utility and perhaps a hint of responders having a little bit longer survival. And therefore there are studies with these agents in the accelerated and blastic phase. Here is one result of azacitidine as a therapy for AP and BP. Again, overall response rate 61%, CR patients about 20%, which gives you opportunity then to go to transplant. And this is where we close the circle. You want to get patients to CR, and then you want them to do the transplant so they can survive. Otherwise, they will relapse and the survival will be still short. And in this case, median overall survival in this particular study was about 13.5 months, but it was a little bit longer for those responders of about 17.5 months. And then there are studies. Ruxolitinib is the JAK1, JAK2 inhibitor that is standard practice therapy for patients with myelofibrosis. When we talk about transformation to accelerated blastic phase, we are usually talking about myelofibrosis patients transforming. They are in bad shape, physical shape. They have a very big spleen, very big liver, so there is utility of perhaps giving them ruxolitinib. And so this is the result of one of the studies, phase 1-2 studies, combination of decitabine and ruxolitinib. And here we have 29 patients. Ruxolitinib was used twice a day as it usually is, in a dose up to 50 milligrams twice a day with a standard dose of decitabine, and overall response rate was 45%, with about 7 CRs and 34% CRIs. So about 40% response rate and a hint of certain extension of the life in responders. Obviously, we already know that ruxolitinib is not active in preventing progression. On its own, is not active in accelerated and blastic phase. That was already published and it's very well known. Here is another study. 21 patients, ruxolitinib and decitabine. Again, up to 50 milligrams twice a day of ruxolitinib with standard dose decitabine. Median number of cycles given 3. Overall response rate 53%. So very good responses. This includes also PR and a hint of a longer, for a few months, life in responders. But again, it gives you opportunity if you get to CR or CRI to get patients to the transplant. So what's the benefit of ruxolitinib in this setting? It is improvement in quality of life, and it is improvement in the spleen and liver. On the right side is the waterfall of responders in the spleen. 84% median reduction in the spleen with this high dose of ruxolitinib. So this is what the value is, really giving it for quality of life improvements. And these two studies are now an evidence of a combination perhaps providing overall benefit in these patients, and a new multi-center phase 2 study of this combination is underway. So overall, how can I summarize what is the possibility of the methylation inhibitors to provide a CR? Again, looking at this summary of the results from 3 studies, I would say it's similar, about 30 to 35 to maybe 40% response rate to achieve a CR, CRI, similar to induction chemotherapy. And therefore, this knowledge has already incorporated in national guidelines how to treat the patients. This is so-called NCCN guideline, United States guideline how to treat patients with post-MPN AML, but also includes accelerated phase. If you look at the schema here, once you have a workup done, in the middle of the graph, you say in upper part AP, accelerated phase, in lower part BP, blastic phase, the therapy is the same. So 10% or more, the same therapy. What we do, if the patient has a possibility of doing the transplant, we induce the remission with hypomethylation agents or intensive chemotherapy. I would usually start with hypomethylation agents for 2 or 3 cycles, see whether I can get it. It's outpatient, it's safer, it's not so toxic, and outpatient means better quality of life. If the patient has no transplant possibility, then we do not use intensive chemotherapy. Guidelines clearly says so. Clinical trial or hypomethylation agents or low-intensity chemotherapy. In this setting, we utilize ruxolitinib for quality of life, as I mentioned before, and I would typically use it at a dose of 10 milligrams twice a day without any dose change based on accounts, just to have it stable at 10 twice a day for quality of life improvements. So where are we going from here? New medications are being developed for de novo acute myeloid leukemia, so why not use some of them in the setting of post-MPN AML or even in accelerated phase MPN? So here is comparison of genetic profile of de novo acute myeloid leukemia and myeloproliferative neoplasm accelerated blastic phases. What you see is complete difference in the genetic profile. But some of them that are important for therapeutic management are highlighted with the yellow arrows. First of all, on the right side, FLT3 mutation is hardly ever present in post-MPN AML, but it's valuable to test for it because there might be occasional patient with it, and then we utilize FLT3 inhibitors. On the other hand, there is many more patients with IDH1 or IDH2 mutations, and therefore, perhaps you can utilize IDH inhibitors in post-MPN AML. So there is some evidence of this activity already. Let's take a look. Here is a very small summary, but very valuable information on 8 patients that had accelerated blastic phase MPN that were treated with the IDH inhibitor. All the 8 patients are listed on the left side, and you can see that patients in a complete remission in blue color achieve it with a single agent, a pill. You have a partial response in a green. So you have a 6 out of 8 patients achieving partial or complete response with a single agent anacedanib, a pill. That gives you opportunity to do the transplant in that setting because otherwise patients will eventually relapse, as it happened in some of these responders. With that therapy, you may, to some degree at least, extend life. And here is another paper that is just now hot in press of 12 patients that were treated with IDH1 or IDH2 inhibitor because it's a combination of 7 patients that have IDH1 mutation and 5 patients that had IDH2 mutation. So in that setting, some of them were treated in a frontline setting and some in a refractory setting. We still had a good response. 3 CRs among 7 in frontline setting, even complete molecular response in these 3 patients, and median response duration was 17 plus months and ongoing. So this is quite a significant improvement over historical results as I outlined before. So targeted agents, and here is an excellent example of IDH inhibitors, is the way of a future, identifying patients based on genetic profile and targeting those mutations for which we have medications either already approved or in the clinical studies. And here is one of the preclinical papers highlighting a synergistic activity of IDH2 inhibitor and ruxolitinib, which is a JAK2 inhibitor. And based on this type of preclinical models, here we have a study underway for patients that have IDH1 or IDH2 mutation in combination with ruxolitinib when they're in accelerated blastic phase. And here is something that perhaps is not very well known, and I'd like to highlight this particular part. This is not really published, paper is in press, but it's important for everyday practice. This is the role, if any, of venetoclax, BCL2 inhibitor, in post-MPN accelerated or blastic phase. We analyzed our own experience of 29 patients, and if you go in a table from the top to the bottom, you will see that about half of the patients were in front line or first line therapy with venetoclax and half, about 15, in a refractory setting. And we give an average about 2 cycles. And what we see is a high degree in the middle of the table of infections, so complications because prolonged myelosuppression. And unfortunately, at the bottom of the table, we also see a high rate of mortality during the first 2 months of therapy. So adding venetoclax as a therapy to post-MPN accelerated all blastic phase MPN, which is post-MPN AML, does not appear to be safe enough. And here I show you the overall survival of the patients when venetoclax is included in the setting. You will appreciate that there is no benefit from it. Unfortunately, there is no apparent benefit from adding venetoclax to post-MPN accelerated all blastic phase patients. The survival is no different on the left side, and comparison to single agent decitabine or combination of decitabine and ruxolitinib in terms of survival, as outlined on the right side, is no different. So we do not actually recommend to utilize venetoclax in AML that originate from myeloproliferative neoplasms. And so I will summarize with proposed treatment schema here for AP or BP MPN, accelerated blastic phase MPN. That includes obviously genetic testing to identify patients with IDH or FLT3 mutations for which we would be using those specific targeted agents in combination with underlying chemotherapy or hypomethylation agents of your choice. If there is no targetable mutation, there should be hopefully a study, a clinical study for those patients where we can combine novel agents in a certain way with the active agents, or if there is no such a possibility, then hypomethylation agent is the first line, followed by intensive chemotherapy only if necessary, and preferred only if it's necessary to get patients to bone marrow transplant, which is absolutely necessary in this setting. Otherwise, disease comes back and life is short. So with that, I conclude my presentation. I thank you very much, and hopefully this was very useful for your everyday practice. Thank you.
Good afternoon, everyone. Welcome to the panel discussion session on application of stem cell transplantation in MPN and management of accelerated and blast phase of MPN. My name is Vikas Gupta. This is my honor to chair this session. I would like to welcome Dr. Andrew Kuykendall from Moffitt Cancer Center and Dr. Verstovsek from MD Anderson Cancer Center. We have several questions from the workshop participants, and there are several themes which have emerged from the discussions from this workshop, which are relevant for this session. So let me start by first question from Dr. Verstovsek. I missed last few minutes of your presentation. I just wanted to ask you, what is the role of ruxolitinib in managing accelerated and blast phase of MPN, and what is your practice of using ruxolitinib in a patient? Let's say a patient comes to you directly in the blast phase of MPN and have never been exposed to ruxolitinib therapy.
This is excellent question, because the patients that come with the accelerated blastic phase may be in different clinical scenarios. And what you're asking is really when we have a patient completely newly diagnosed or presenting to us in accelerated blastic phase, and they are not on any specific therapy, no JAK inhibitor, nothing else. What we would be doing is, apart from looking whether there is a possibility to doing the transplant, we would be treating that patient, if possible, with hypomethylation agent in combination with the ruxolitinib if that patient has symptomatic splenomegaly and general systemic symptoms from myelofibrosis. So simply, everybody gets, if there are more than 10% blasts, hypomethylation agents, either azacitidine or decitabine, for 2 and 3 months to see whether we can get those blasts below 10%. While we are looking for the transplant donor, and if there is a transplant donor and blasts are lower than 10, we go with the transplant. In parallel, if there are symptoms from spleen or general systemic symptoms, we go with 10 milligrams twice a day of ruxolitinib, which is good enough for control of the symptoms, and it does not cause myelosuppression, and we keep it steady throughout those times. We don't adjust the dose, just steady 10 milligrams twice a day.
Okay, so I would like to also ask Serge, what is your experience of using venetoclax in combination with hypomethylating agent as an upfront therapy in patients with accelerated phase or blast phase?
The story with venetoclax is quite interesting, because if one looks back at all the studies that were done with venetoclax in the acute myeloid leukemia, they were all excluding patients with post-MPN acute myeloid leukemia on purpose, because the biology of the patients that develop acute myeloid leukemia from MPN is different than de novo acute myeloid leukemia, not only in genetics. We talked about the genetics profiling being so different. Biologically, BCL2, which is a target for venetoclax, it's not prominent in post-MPN AML. It is different part of the BCL family members. It's BCL-XL. So venetoclax being targeting BCL2 does not have a role. biologically. And now we have clinical evidence from our 29 patients from different studies where we did, unfortunately, I would say, unknowingly or trying to see where this will work, we treated those patients by adding the venetoclax either to hypomethylation agents or chemotherapy as described. We did not see any clinical benefit by adding the venetoclax. We had unfortunately seen prolonged suppression of the blood cell count and more complications and no benefit at all. So we are staying away from venetoclax when it comes to acute myeloid leukemia patients that are developing that from MPN.
Our experience has been slightly different. It's anecdotal experience in 4 or 5 patients, where a couple of patients achieved CR or CRI, and one patient achieved morphological leukemia-free state. So I was interested in sort of understanding what is your experience, Andrew, on this.
Yeah, I think it's variable also, and I've been in discussion not just with the MD Anderson group, but centers across. I think that we were all excited to potentially add venetoclax to our regimen since one, AMLs do so poorly. Venetoclax with HMA looked pretty promising, and we know that post MPN AMLs do extremely poorly. So having something that might improve their survival was something that was extremely encouraging. I think our experience has been similar to Serge's, where we just haven't seen really marked improvements in outcomes like has been described with maybe the elderly unfit for chemotherapy populations with AML. But to your point, I think that we know that the transformation to blast phase within a myeloproliferative disease occurs in many different ways. So there may be a subpopulation of patients that are susceptible to adding BCL2 inhibition in conjunction with HMA. So it may not be like that for everyone. So we kind of need to figure out which ones that's a reasonable option for and which ones we should definitely avoid it.
Sure. Yeah, no, cytopenia is a problem. Like the patients we have treated, we usually sort of, during the second cycle of the treatment, we go into 2 week on, 2 week off type of approach in that group of patients. There is a question from Dr. Harris Ali. How about using CPX351 or navitoclax in blast phase of MPN? I am not aware of any data on navitoclax in blast phase of MPN, but Serge, do you have any experience of navitoclax either as a part of a clinical trial, or what is your experience on using CPX351 in blast phase of MPN? And Andrew, also welcome your comment on this.
The indication for CPX is in a second line or secondary acute myeloid leukemia after myelodysplastic syndrome. If you look at all the studies that were done with the CPX, the initial studies did allow any type of acute myeloid leukemia patients, but then all the studies that led to its approval were specifically focused on patients that were developing acute myeloid leukemia after MDS. And this is the label for utilization of this in post-MDS AML. And so obviously you ask the question, why is that? Why not in post-MPN AML? Well, because it doesn't work, right? So we asked the company, and that is not really very well published in a clear sense, whether there is any experience. And there was experience, and there was no response at all. And so we also have some patients, but the numbers are small. This is something that we are preparing also for a letter for publication, that there is really no reason to utilize that is even off-label CPX in post-MPN AML. It is active in post-MDS AML, but not in other subgroups.
Okay, so Andrew, what is your experience on this?
Yeah, I mean, I think it's kind of boring. I do agree with Serge on this. For the most part, but it's going to be similar to the answer I gave with venetoclax. I think you do have some MPN patients who kind of go through this MDS phenotype or have a disease that has more of an MDS MPN phenotype and then develops into AML. And so we've used CPX351 rarely in these post MPN AML patients. In general, I think there's been some difficulty with prolonged cytopenias. We have gotten some remissions from this, but I think you run into the same problems as venetoclax, where I don't think the responses are that much better, and the prolonged cytopenias do become an issue.
Okay. So question for you, Andrew. Mechanism for transformation are complex and perhaps multifactorial, and acquisition of risk factor is a dynamic process. So you have highlighted the importance of various myeloid malignancy mutations in your talk, and several speakers in this meeting have highlighted their role. So in a patient in a chronic phase of MPN, how often do you repeat NGS during the disease course, or are there any particular parameters, which will, on the basis of which you will act to repeat NGS in these patients to see whether these patients are clonally having clonal evolution or not?
Yeah, it's a good question. And I think it's something patients often ask as well. I think, basically speaking, there's three different ways we can look at this disease in clinical practice. We can look at labs when they come in. We can look at bone marrow biopsies. We can look at the molecular abnormalities that are associated with it. It's easy to look at labs, so we look at that every visit for the most part. But doing a bone marrow biopsy or doing an NGS panel has, implications that are a little bit, it's a little bit more difficult to do that than to do lab work. So I don't have regular periods of time where I do any of those things, but if there's ever something happening with the lab work or the symptoms of the patient or something clinically that I need to know more about the disease, then that's a reason to do either an NGS panel or to do another bone marrow biopsy. And they're kind of similar reasons would bring me to do both of those things. I think things that kind of always pique my interest is when someone who's always had stable counts, all of a sudden those change. I want to know what's the molecular driver behind that. And oftentimes that'll spur me to do a bone marrow biopsy as well.
So significant change in the blood counts would be a trigger factor for you to repeat.
Yeah, blood counts, clinical status, any time where I can't explain what's going on based on the information I previously had.
So there's a question from Dr. Lucia Masarova. She has asked two questions. The one question is basically, does the VAF of TP53 make a difference in upfront stem cell transplant indication? What to do with patients who have VAF of 5 to 10%? The answer is we don't know. We have not treated enough patient, or I haven't come anything in the literature where impact of VAF on the outcome of transplantation is reported in the myelofibrosis. We do have a study which we presented at ASBMT meeting. This is the CIBMTR data, where there were about 23 patients who had TP53 mutated post-MPN AML, and in those 23 patients, the presence of TP53 mutation those patients had a very poor outcome in the blast phase. We don't have any data in the chronic phase yet, because there are very few patients in that disease indication. Dr. Masarova's second question was there a difference in those who failed JAK inhibitor therapy versus underwent stem cell transplant still having response? What is your take on timing of transplant in suboptimal JAK inhibitor responder? So in patients, there was a difference between patients who failed JAK inhibitor therapy versus patient who underwent transplant while having response to JAK inhibitor therapy. But we have not looked at this properly yet. When I say properly yet, we have not taken into account how long patient who had failed JAK inhibitor therapy were on JAK inhibitor before they underwent transplant. So we are looking at this a little bit more comprehensive manner. So we may have answer in few months' time. There is another question from Dr. Odenaki, which is for Serge. How do you define or assess response in patient treated with accelerated phase or blast phase because there could be significant difference in the marrow versus peripheral blood blast count. So Serge, what is your response criteria? How do you define CR or CRI in these patients who undergo either hypomethylating agent or induction type of treatment?
This is a really good question, but it's tied to the overall goal. Why are we treating the patient? The goal is not only to get to the CR or CR with incomplete recovery of the counts or the PR, because we're going to struggle among three of us to agree on what exactly that means. And so that's why in some of our studies in these patients, retrospective analysis of some of these attempts to decrease the blast, we utilize the term a benefit, where the white cell count will be going down, the blast will be going down from, let's say, 16 to 8, and what is that? Or 11 to 9, or things like that. Does this mean anything? And so in the assessment of the survival, a benefit had a role as well, not just the CR or CRI, but the control of the signs and symptoms or clinical characteristics of the disease without achieving those specific definitions that are valid at that point in time. So we can discuss about it, but the goal of the therapy is basically simple. It's to decrease the blast below 10% and get the patient to the transplant. And so the best way is to get the bone marrow biopsy after 2 or 3 cycles or whatever you prescribe and see whether you did go from 16 or 28 or any other number to less than 10. And if you have a donor identified in the meantime, go for it, because it's not going to last for too long, and it's not necessary to have it to less than 5. If it's 7 or 9, as long as it's less than 10, that's the goal for me. So there is distinction between the definitions of the therapy efficacy by standard criteria. I endorse that for uniformity, but also the clinical applicability of that is a little bit diminished, because we just want them to respond, and we define this as less than 10% of blast and go for the transplant.
I guess a typical AML type of criteria are very difficult to apply in this disease setting. And perhaps sort of, the best you can get to these patients is putting them back into chronic phase. That's what you're saying, to blast less than 10% and put them back into the chronic phase, and then try to sort of, quickly move them to transplant as soon as a donor is available. And there are some center-specific sort of, practices. Does your center do transplant, let's say somebody with a 10%, less than 11% blast count, or they're very specific, you have to have less than 5%?
No, it is really not that specific. These are our own internal desires to have a patient less than 10. On one hand, you see that the disease is sensitive to therapy, right? You debulk the disease from 25% to less than 10, and that's great. So the disease is sensitive, now you go to the transplant. But if you get to 11, well, what does it mean, 10 versus 11 or 12? So we are not that harsh, because remember, we are talking about the very, very short survival if you do not go to the transplant. So there is some flexibility here. It's not absolute, right? And so we try our best to diminish the disease or debulk it and decrease the blast. And if it's 10, that's really good. If it's close to 10 and we can do better, that's fine enough. Let's go for the transplant to try to save the life of the patient.
Thank you, Serge. So there's another question, which is, Andrew, for you. With regard to inflammation and progression, which came first, chicken or the egg? Is inflammation driving the progression, or clonal progression driving the inflammatory response?
Yeah, I mean, I think it's both. I think that there were great talks yesterday that really touched on this in much more detail. And I think the more we get a feel for this, the more data that comes out. It seems that inflammation seems to, I mean, at the heart of it, right? Mutations are a random event, and so that's shown by Dr. Bahar's data. When the more closely you look at and the more sensitive methods you look for CHIP, the more you find. And then if you look at a sensitive enough level, it's there in 100% of patients. So these mutations occur seemingly randomly, but they occur in everyone. And then the question is, why do some mutations, when they do occur, become disease, and why do others not? Or why do they become 1% and never progress past that, and why do others progress to a full-blown MPN or an AML? And so I think that's where this inflammation role comes in, and it's obviously very complicated. I think that this meeting has helped to show that. So to me, I think it's kind of this positive feedback loop where the disease itself is inflammatory, and it comes on an inflammatory environment, grows in an inflammatory environment, creates more inflammation, and then like begets like, and this positive feedback loop is difficult to control. And the key is figuring out what inflammatory pathways are important at which time in the disease, and how do we do that, and how do we target those safely.
So do you do any test in the routine clinical care outside the setting of clinical trials, where apart from CRP, you study any cytokines in routine clinical care, or based on the results, you do anything different?
No, I mean, I wish that was part of what we did. I mean, I think that that's important, and I think that field is going to blow up soon to better understand those things. But certainly not as part of routine clinical practice, but I think we're starting to see the importance of these cytokines, and if we have to figure out a way to kind of utilize that information clinically to going forward.
So there's a couple of questions from Dr. Jajan Medanat. Do you consider haploidentical transplants for older patients with primary or secondary myelofibrosis? Yes, we do have a haplo program for myelofibrosis patient. Our approach for haplotransplant in myelofibrosis patient would be either patient who have molecularly high-risk disease or patient who have failed JAK inhibitor therapy. Those patients we would consider for haploidentical transplant. The data on haploidentical transplants are somewhat limited. There is a collaborative effort going on in North America, and we should see some data at ASH this year. What I've sort of so far observed is that engraftment is not an issue if you use post-transplant cyclophosphamide based protocol in these patients. There's a second question from Dr. Jajan Madanat for Serge. For patients with accelerated phase myelofibrosis who are IDH1 positive, would you start HMA or targeted therapy upfront or combination?
And this is, I'm sorry, just the first part of the question was in which type of the patient?
Sorry, accelerated phase myelofibrosis.
I would start combination. Yeah, I think that the combination appears to be a really good choice. We have evidence that both parts of the combination would be working. Certainly that can be individualized. One can try just IDH inhibitor, and that may be in a patients who have a high IDH mutation allele burden that would be useful to test for. When you do the NGS testing and you identify that mutation, you say, well, what's the allele burden or VAF that you were talking about? And if that's very high, that is probably the driver mutation then for the transformation. And you can try just the pill, the IDH inhibitor, and see whether it's going to work. It is valid try. Our experience is very small, as it was presented on one of the slides, only 12 patients so far. And there were some of the patients that were given, maybe that was not clear because of complexity of the slide, that were given IDH inhibitor alone. It did not really work that well with the constraints of having 12 patients in total, right? So the combination appears to be favored, as it's usually the case in aggressive types of the diseases. We are talking about accelerated blastic phase, where there are many other chromosomal abnormalities and other genetic abnormalities. So I would say in best case scenario, my choice would be combination, hypomethylation and IDH inhibitor together.
Thank you, sir. There's a question from Dr. Hamburg. Is there data in patients with autoimmune disorders and presence of MPN, either prior to treatment for their autoimmune disorders or after treatment? So I guess the the question is mainly how do you deal with the issue of autoimmune disorder and MPN together? Andrew, do you want to?
Yeah, I mean, I think that we know that autoimmune diseases and myeloproliferative diseases, they're more common to see autoimmune diseases in that context. And I think that you can certainly tie that into the idea of inflammation. If you have some sort of chronic inflammatory process that may allow the MPN growth or MPN stem cell growth to have a fertile environment to expand. I think that autoimmunity and myelofibrosis, there's also autoimmune reasons to have fibrosis in the bone marrow too. So managing these coexisting issues can be problematic, and it's something to take into account when we think about the therapeutic strategies that we're going to use, because certain MPN therapeutic strategies certainly should be avoided within the context of autoimmune diseases, and others may provide some benefit. So it's certainly something to take into context, and I always advise learning as much as possible about the specific autoimmune disease before starting therapy, because many patients are labeled with an autoimmune disease that's kind of an autoimmune disease NOS, and getting some finer details before starting therapies, I think, is important.
So I had a personal experience of treating a patient who had advanced rheumatoid arthritis along with myelofibrosis with Jakavi, and this patient was previously on methotrexate, and and again, there are several JAK inhibitors which have been approved for rheumatoid arthritis, but this patient had a dual benefit from Jakavi going on to. I had a couple of patients with ulcerative colitis, but this didn't make any difference in those patients. So I guess perhaps it depends on type of autoimmune disorder. Serge, any experience on this side?
I agree with you that they are sensitive to JAK inhibition by the common, I would say, pathway of JAK-STAT being involved in both hematopoiesis and inflammation. And so I think that many of us may have patients that have one or the other type of autoimmune problem. I recall some patients with the psoriasis where that went away. And so I would think that one therapy kills both birds here.
So we have a few more minutes. So I'll ask one question. At this meeting, the role of TP53 pathway as well as RAS pathway mutations as key drivers of blastic transformation has been highlighted by several speakers. So Serge, what is your approach of TP53 mutated MPN these days? Do you use any specific therapies targeting TP53 pathway, such as APR246 or magrolimab, or any drugs using RAS targeted pathways?
Yeah, so the role of the RAS, let's start with the RAS, has been only highlighted more recently in a paper and presentations at the meetings, and it has been even included in some of, and we did that work, of prognostic factors. So it is really rare actually to have a RAS pathway or associated RAS pathway abnormalities in the chronic phase, but if they are present, as you said, this is the indication for more aggressive disease, and it's reasonable to include it in your prognostication efforts and implementation of more aggressive therapy sooner, talking about the transplant, sooner rather than later. We do have studies with the RAS pathway inhibitors underway, not specifically for patients with myelofibrosis or specifically on any other type, but that is relatively new, and we don't have much experience to say whether this really would contribute to overall success. For P53, that information has been around for quite a long time. A quarter to a third of the patients in blastic phase have it, hardly anybody at the beginning, and therefore you don't really do much about it in the chronic phase, but once you transform, whether you can target that pathway, like you said, there are clinical studies specifically for patients with myelofibrosis, with acute myeloid leukemia with that mutation. We would include those patients, our own post-MPN AML, in those studies that target P53 pathways. That is the way to go. That follows the pathway of identifying targetable mutations from FLT3, which is very rare, to IDH, 20-25%, P53, 25-30%. I think we are dividing our MPN, post-MPN AML group in groups based on the profile, and we will soon enough have a number of other targetable subgroups for implementation in everyday practice.
Andrew, what is your practice in this area?
Yeah, I agree. I mean, we've seen kind of the role of TP53 targeting agents kind of grow over the last few years with some of these agents that are being used in MDS and then certainly in AML. I think whenever you get to AML, post-MPN AML, you're looking for any clinical trial, and if you have a targeted agent that could be an option, that would be perfectly reasonable and preferable. Unfortunately, in the chronic phase, most of the ongoing trials with APR have excluded chronic phase MPN patients. So we really don't know the role for that agent in the chronic phase at this point. But I think that when we start to see P53 mutations with high VAFs, those don't stay in the chronic phase for too long. And so getting them ready for a trial is reasonable. And then if you're able to clear the clone and get a remission, then going to transplant as quickly as possible is reasonable. And I think that APR-246 is also being looked at as a post-transplant maintenance strategy for patients that don't get it up front. Magrolimab, similar exciting results that we're seeing with P53 mutant patients. So that agent in the post-MPN AML setting is perfectly reasonable. And then to kind of building on what Serge said about RAS pathway, I think that's the next pathway that there's many people looking at different inhibitors. It's RAS is around and been implicated in basically every cancer, but targeting RAS has been extremely challenging and with limited success until recently. So now knowing that it plays a role in myelofibrosis and myeloproliferative diseases, we need to kind of work as hard as we can to adopt those strategies that are showing success and see if they're relevant for our patients.
Okay, so last question. TP53 mutated PV or ET patient, how do you choose what cytotoxic therapy? Do you go with your sort of regular type of use hydroxyurea as you would use in any other patient, or would you avoid it? What's your thoughts?
Yeah, I'll say that I have a few patients with P53 mutations at low levels. I think that's one of the challenges when you do NGS sequencing on PV and ET patients is sometimes you get findings that then give you some pause and you're not exactly sure how to approach that. I would say in those patients I've tried as hard as possible to avoid using hydroxyurea. I'm not sure a wealth of data behind that, but in those patients I have opted to either use interferon or if they're CALR mutant patients that don't really need cytoreductive therapy per se, then I'll try to avoid it in those patients. So I don't know, Serge, what do you think?
Yeah, I agree with you. First would be to assess the thrombotic risk, and with the modifications, for example, for prognostication in ET, many of the traditional high-risk patients don't need cytoreductive anymore unless they are JAK2 mutation or had a thrombotic risk. So a number of patients in ET space, at least, that absolutely need cytoreductive therapy is somewhat smaller than it used to be. But then the number of patients with the P53 mutation is also extremely small. That maybe you have a collection of those, but these are really rare patients. And I agree with you. You would try to, if you remember, give them interferon, and if the interferon is possibility, it depends on the person, right? 75-year-old, 80-year-old versus 60-year-old. There also needs to be accounted for whether it's feasible, and what is the risk of the transformation or contribution of the P53 to transformation in a period of time the patient has. So we need to be aware of it and then individualize, basically.
Yeah. So thank you, Serge. Thank you, Andrew, for a very lively discussion. With that, I would like to close this panel discussion, and I would like to again thank you, Serge, Ruben, and Naveen for organizing this beautiful meeting virtually. And this is first time I've spent whole 2 days sort of glued to the computer. and it didn't feel like that we were missing anything, but hopefully we can have an in-person meeting next year. So with that, I would pass on to Ruben for his final comments.
Wonderful. Well, first let me thank all of you from this last panel. Andrew, Vikas, Serge, that was really fantastic. That was such a great way to close it out. Certainly it's been a wonderful 2 days and a lot of things to cover before we close, and certainly give chance to my very good friends and co-organizers of this meeting, Serge and Naveen, to be able to share their thank yous as well. But it's, again, when the pandemic hit, it would have been very easy for us to just have canceled this meeting. You know, it's been a very busy summer. We've all had a lot going on, and that would have been the simplest. So, you know, just enough cannot be said for the energy that Naveen, Serge, you know, had brought to us really trying to move this forward, because of the very important nature of this discussion for our patients with MPNs and to really bring us together as a community. Indeed, the result has been, the impact, I think, has really been that much more meaningful. At last count, we had near 1,000 people who had registered, as well as over 30 countries that people were live streaming this meeting. Now, after this meeting, it will be present on the website. Takes a while to get all the videos kind of organized and things of that nature, but where all the content will be out there, that again, people can register and be able to watch, dissect, what have you, really into the future. We'll probably leave it out there as content till next year's meeting, when we have a chance to update that on many different levels. So the impact's really been spectacular. Now, obviously, we want to make this a tremendous success moving forward, and to really play a special role in the various niches of MPN meetings in terms of discussions. So your evaluations really are very important in terms of how could we do it better, other topics you would like to hear, speakers that you thought were particularly helpful, things that you thought were either duplicative or probably less helpful. Again, any of those sorts of things we would certainly welcome to have this be the best that we can. You know, my co-chairs and I, we've been chatting as the meeting has been going on, clearly view that, you know, our goal of a workshop should continue into the future, but the ability to have many participate from around the world is a tremendous bonus, and we will look to have it in a hybrid fashion so that it could really accommodate both. Now, clearly, many individuals to thank before I hand it over to my co-chairs. But first, let me thank Sharon Hill and the people of the Mays Cancer Center at UT Health MD Anderson CME office that really helped put this together. This is a very special group. Sharon Hill and her group run a small meeting you might have heard of called the San Antonio Breast Cancer Symposium. So that is the largest breast cancer meeting on earth. And as you might imagine, that similarly is going virtual kind of in this process as well. So they have been kind of learning as they go. We've learned a lot from our good friends and colleagues at AACR, the American Association of Cancer Research, and others kind of in this process. Next, certainly to thank Charlie Grieve and his colleagues at Vijay Hemag. He came to me very early on in this process and volunteered to help in any way that he could, and has really been a tremendous partner in helping to both get the word out about the meeting, as well as for Vijay Hemag, the wonderful work they do in terms of being able to share content out there in heme malignancies. Our colleagues at Brandcast Health have been fantastic. Andriana, Peter, Benjamin, all of you have had a chance to interact with them. They've really been wonderful colleagues and have done a spectacular job. Obviously, we've been able to conduct this because of the very generous support and engagement from our colleagues across the pharmaceutical industry. Again, as with all of these meetings, these come as unrestricted efforts so that we're able to discuss things freely as we would, but they encourage the discussion. So those sponsors at Insight, Dover Pharmaceuticals, CTI Biopharma, and Pharmacentia, exhibitors at Insight, Jazz Pharmaceuticals, Takeda, our colleagues at the MPN Research Foundation that are great friends and colleagues on many levels, and the educational grants from Constellation, Insight, Cartos, Protagonist, Sierra, and STEMline. Clearly, a big shout out, as I mentioned at the beginning of the meeting, to Robin Scherber. She had played a big role in both the energy and the ideas for the meeting. She stepped away from the planning when she took her role at Insight. But again, we're deeply grateful to Robin for all of those efforts. And of course, enough cannot be said for my wonderful colleagues, both at Naveen and Serge. I've been here now in Texas. It is exactly 3 years, I think almost to the date. And they have been tremendously welcoming. They have been phenomenal friends and colleagues really throughout my entire career. So really grateful to them and the fun and all of us putting this together. We'll have Serge close out the meeting, but Naveen, why don't you share some thoughts from the past couple of days, some things that are some of the takeaways for you, some of the things you're excited about.
Well, thanks, Ruben. And as you give so much thanks to all of us on behalf of Serge and myself, we'd like to give you thanks, because without you and your energy and your dynamic presence, none of this would have happened. So just a kind of quick thank you to you. Okay. I think that a couple of takeaways, as you know, I was monitoring our social media feed on Twitter very closely. There was a tremendous amount of buzz and activity. So I'd like to thank everyone out there for engaging, particularly led by Dr. Nicole Cousin, our PEDS AYA MPN expert. I was really pleased to see that kind of engagement. I think the mix, Ruben, of the recorded sessions that were quick, heavy hitter, fast paced with the live sessions gave kind of a unique mix I have never seen before in a virtual format that made it must not miss. I didn't even want to go to the bathroom to miss even 30 seconds of this. So I really think that was a big takeaway from this. In terms of topics, I think it was great that we had an emphasis on the old and the new. I think that's one theme that our viewers will take away. Multiple sessions on interferon, thinking about drugs that have been around for decades, JAK inhibitors, and then now the newer agents. Not many meetings will show that kind of a mix. So I think thinking about biology and translation, single agents, and now we're moving into the combination approaches. So that's one takeaway. A second takeaway, as we saw from some of the talks, is the emphasis on inflammation, Ruben and Serge. So the concept of CHIP, as highlighted on day one, Dr. Moliterno and Kuykendall showing these kind of new risk factors, along with Dr. Fleischman with cytokines and inflammation, many of which were new to a lot of us, some of these new factors. So let's keep an eye on that. And then finally, I think one great idea really spearheaded by you and our Italian and European colleagues was the COVID session. I have not seen a session like that all year, with its emphasis on COVID as a blood disorder, as a thrombotic disorder. It was phenomenal. So, and it was really heartwarming to see Dr. Jerry Spivak, Dr. Silver, especially with the New York meeting being canceled this year. This may well be the one time that all of us in our field get together for a year and a half. So those are my takeaways. And with that, I'd like to turn it back to you and to Serge to close up. Thank you.
Before I hand it over to Serge, our organizers just sent us a little text that in the end, 1,360 unique visitors during this past 2-day period of time. And obviously it'll echo into the future. Of course, I was remiss, not really, I forgot to thank, of course, most importantly, our faculty. Indeed, it is one thing to be invited to a meeting. It's another thing to be invited to a virtual meeting where you both have to find time to rehearse, to tape your talk, and then also be present in real time for panel discussions, including our colleagues from Europe who attended, frequently very, very late at night. So again, these things only are a success because of our faculty who participate with them, bring their energy, their time, and their talents to these discussions. So a tremendous thanks to each of them. Serge, please, my friend, why don't you close us out?
I think this was amazing 2 days. I like to also thank you both, Ruben and Naveen, for amazing effort in putting this together with all the other team members, from the organizers to the faculty, as you mentioned, to sponsors. And I like to highlight the number that you said, 1,360 unique visitors, which is amazing. You, Ruben, said that in San Antonio you have the largest breast cancer meeting on earth. What we are witnessing here is the history making. We now in Texas have, I have no doubt, the largest virtual MPN meeting on earth with 1,360 patients here. I'm sorry, participants here. But that's actually the point. We have opportunity to offer for free and in easy way, not only for us as doctors in the field to get together and discuss it, but we offer this to public, and we have many patients and many are our nurses, physician assistants participating, which for me is the beauty of the moving in these difficult situations with pandemic to online setup, where we actually have a benefit of it and enhancing our ability to spread the knowledge and share it and get everybody to work together even closer. So maybe I'll joke, but I would say I refuse in-person meeting anymore. I want only the online meetings from now on with so many people participating and sharing the experience. So this is only the beginning. We're going to have a next one next year, same time, same place, in Texas, online or in person. I love the combination that you suggested. I'm really looking forward, and I really, again, thank everybody, the listeners, participants, organizers. It was a beautiful experience. Thank you so much, everybody, and stay well and stay safe.
Bye-bye. Take care, everyone.